Hi and welcome to Physiotutors podcast episode 50 with Anju Jaggi. Anju is a physio consultant shoulder specialist at the Royal National Orthopedic Hospital in Stanmore, UK. She's a past president of the European Society of Shoulder and Elbow Rehabilitation, abbreviated as EUSSER, and a published researcher with a particular interest in shoulder instability. Thus, in this episode, we will talk about all things shoulder instability. You will learn about the Stanmore classification and structural damage after dislocations. We will discuss the typical patient with shoulder instability and how Anju's examination process looks like. We will touch on muscle activation patterns, surgery, and how physiotherapeutic management of a patient with shoulder instability could possibly look like. So make sure to listen to the whole episode. Hi Anju, welcome to the podcast. It's an honor to have you.
Hi, thanks Kai, and thank you for the introduction. Very, very kind and very accurate. Thank you very much.
Yeah, no worries. And we have a lot to talk about, so let's waste no time and let's jump right in. So Anju, what is shoulder instability? Is it something that can be measured objectively, or is it a subjective patient complaint?
So probably the best way to define instability, we're essentially talking about the inability of the humeral head to maintain on the glenoid fossa. Okay, now that can obviously result in a transient subluxation, so a sensation for the patient to feel like the shoulder may be slipping or giving away, to anything like a partial displacement or a full dislocation. It's symptomatic, so it's what the patient is perceiving, and also I suppose a way of documenting and having objective, viable measurement of it is usually then seeing it on X-ray. So it's very difficult probably to objectively measure, let's say, a partial displacement or occult instability, but a full dislocation is often documented through an X-ray. Also, don't forget that symptoms can also include pain, a feeling of the giving way, and also kinesiophobia. So I think it's important for us to recognise is that absolutely the primary symptom is one of feeling of instability, but it can be associated with other symptoms.
Okay, and if a patient reports pain, what are the nocibic drivers, or not the nocibic driver, the nociceptive drivers in the unstable shoulder? Like, why does it hurt?
Do you know that's quite a tricky question. So I think it depends on the type of instability. So if we take the more common, the traumatic, the kind of the classic anterior dislocation of the shoulder, I think at that moment what we do know is that patients experience pain at the time of dislocation. So it is the event. Okay, the structures that are probably getting under stress or force, the labrum, the capsule, they're probably are mechanoreceptors, and within that they're getting a pain sensation or basically a brain signal that there is an injury to the shoulder. What's interesting though is that once that shoulder is put back into joint, those patients then don't go on to have ongoing pain. So pain, I think, in a very straightforward traumatic type of dislocation is at the time of onset and as a result of the dislocation. When you start talking about more generalized pain, so patients complaining of pain sort of in a general achy sensation, it's more global around the shoulder. Some patients might describe pain going down the arm. That pain generally tends to be more in the atraumatic group, and that is more a myogenic type of pain. So it could be a muscular imbalance, perhaps compensatory mechanisms. And then obviously for some patients, if you start to get characteristic pain like burning or tingling and or referring pain into the hand, then you've also got to have a suspicion of a neurogenic component. So has there been an associated nerve injury, a plexus problem? These type of symptoms are usually rare in the traumatic group. Okay, so more global pain, nerve-related pain, we tend to see that more in a kind of complex atraumatic group, unless the trauma group have had a significant nerve injury, obviously. Other things that can cause mechanical pain. So when the pain is more localized at a point, so don't forget about the AC joint, because we're talking about instability, and we're talking about trauma possibly. So don't forget, it's not just about the glenohumeral joint, but pain from the AC joint, pain from biceps, and probably clicking, grinding, and sensations of perhaps superior labral type of pathology as well. So, but essentially in instability, it's not usual to have pain as the major complaint. It'll be the instability that's the main issue. Having said that, though, like I said, in a more complex group, as we come on to talk about that through this podcast, the group I see do have complex pain associated with atraumatic instability. And that, I think, is starting going into central sensitization and other forms of sort of why those symptoms are occurring.
Grant. And if we look at different classifications of shoulder instability, I mean, we have the Stanmore classification with the TUBS, the AMBRI, and the Neuromuscular group. Can you talk to us about that? Like, what are those groups and how do they differentiate?
I think probably a really simple way is that it was Matson and Thomas, the classifications of the TUBS and the AMBRI group. So essentially, we've got two primary reasons why shoulders become unstable, either due to trauma or no trauma. Okay, so your atraumatic versus your traumatic. If you take your traumatic group, they are by far the most common. So probably about 90% of the kind of dislocations or feelings of instability that we see in general practice, it's highly likely it's been related to some kind of event. Trauma is usually described as some kind of high-forced injury. So when we take the TUBS group, which on a Stanmore classification is talking about the type 1, the top pole of the triangle, you're talking about traumatic. These patients will generally dislocate, but usually in one direction. Most commonly, that will be anterior. So we've got unidirectional. We then may have an associated pathological lesion. And so the B in the TUBS will stand for a Bankart lesion, which is essentially disruption of the capsuligamentous structures. The S in that acronym generally stand for surgery. Now, we can come on and debate about that, but it has been through that classification recommended is that the higher the force, the more the trauma, the loss of structural stability to the joint, and therefore surgery may be indicated. Okay. As you then take the second group, which is the atraumatics, that's your AMBRI group. So on the Stanmore classification, that will be your type 2. So we're now coming onto that side of that right-hand side pole of the triangle. This acronym is your atraumatic, multidirectional, and I'll come on to talk about that, bilateral, rehabilitation, and if that fails, then it can an inferior capsular shift can be offered for those patients. These are less common, okay, and I would describe these people as the kind of either born loose or become loose, okay. So these are patients who have using the arm, perhaps particularly above shoulder, overhead, your throwers, your swimmers. So you might end up with pathological laxity through repetitive overuse. And with that, you might end up with some labral pathology. Okay, so there is some perhaps subtle structural abnormalities, but they're not as a result of any significant trauma to the shoulder. Now, based on really the key paper was that Rockwood back in the 1980s, they took patients with traumatic and atraumatic instability. They gave both those groups of patients a course of strengthening based exercises focusing on deltoid, cuff, scapular stability work. And what that paper showed was that the traumatic group still seemed to have a high recurrence of instability despite strength training, whereas the atraumatic group actually had a really good result. About 80% of patients did really well with rehabilitation. As a result of that paper, that is why when we talk about atraumatic instability, we generally recommend rehabilitation, okay? The thing that you have to remember within that, though, is that Rockwood paper was not a randomized clinical trial. It wasn't blinded. There was probably, if we were reviewing that paper, that it wasn't at a high level of methodology. but it is very much then set the scene. So when we talk about atraumatic instability, our recommendation generally is a course of strength training, physiotherapy. But if that fails and there is some labral or capsular dysfunction that could be conducive to a surgical procedure, most commonly placing some anchors to reduce the volume of the capsule or to repair the labrum, then that can be the next course of management. And I'm going to come on to talk about our clinical trial later on in this podcast, and we will give you about our updated results now is if that type of surgery in those patients.
Yeah.
So that's your AMBRI group. Now, the Stanmore classification also include a group that we talk about as muscle patterning. Okay, and this is on the bottom axis of the triangle and it's on the left-hand side. These are patients, again, who've had no trauma to the shoulder. They generally have hyperlaxity, not just at the shoulder, but there may also be generalized hyperlaxity.
No.
But the distinction between a type 3 and a type 2 is that when you do an MRI scan or when you look inside the shoulder, it is essentially pristine. It is normal. There is no pathology per se or real abnormality of both labrum and capsule. There may be capaciousness, there may be a real laxity to the shoulder, which could be a normal variant, which could be part of just their congenital makeup.
Yeah.
So the general recommendation with the Stanmore triangle is you have these three polar groups, but sometimes you can have a continuum between them. The other thing to mention about the type 3 group is we describe as well that there is an obvious muscle patterning type of abnormality. And what I mean by that is that when you observe these patients moving, you could see a kind of a dyskinetic pattern of the scapula. You might see global muscles activating more. You may also see an obvious displacement of the shoulder. So that I think a better way to describe it now, and I'm going to talk about my journey and how I've evolved my thinking, but I think we're better to say that these people have a very obvious movement disorder to the instability. But in terms of the mechanics and the architecture of the shoulder, it essentially looks normal. The Stanmore triangle then allows you to kind of recognize that there can be a continuum between these groups. So you could have a patient who perhaps has had a traumatic injury, has had perhaps stabilization surgery, but goes on to get in recurrent problems, but more as a result of muscle discoordination. Does that? So what you're then dealing with is someone who's got a type 1, but also with a 3 element. Okay. So what I think the triangle allows us to say is that actually there can be heterogeneity, there can be continuum of pathology, but to keep it simple, what I would say to the group, to the listeners, is that the more the trauma and the more the structural damage, the more a surgical procedure may be indicated. The lesser the damage and the lesser the trauma, you are looking at very much a muscular control issue, and that should be served with rehabilitation.
Yeah, thank you for your detailed answer. If we take the TUPS group, so the traumatic group, what kind of structural damage do we usually see, or do we often see in patients with traumatic dislocations? You already talked about the Bankart lesion. Mm-hmm. What else is there, and how prevalent is that?
Okay, so obviously so there can be damage to the soft tissue structures, as we've talked about. So Bankart lesion, labral tears, disruption of the capsules, attachment to the glenoid. But then you can also get bony damage. And the most common would be a Hill-Sachs lesion. So that would be effectively a dent on the posterolateral aspect of the humeral head. So if a shoulder is going to dislocate anteriorly, as that humeral head starts to translate forwards, it then comes in contact with the glenoid and almost creates a dent on the posteral aspect of the humeral head. And that is called a Hill-Sachs lesion. In terms of prevalence, Hill-Sachs can be up to about 50%. I think approximately 50% of dislocations may have a Hill-Sachs lesion. And then it comes down to the relevance of that degree of bone damage. And perhaps it becomes more relevant the larger the Hill-Sachs lesion is. And we talk about an engaging Hill-Sachs. So in other words, if you have quite a large defect on the posterolateral humeral head, and you've got a Hill-Sachs that when you then put the shoulder into an apprehension position and it engages with the glenoid, that may be more indicative of a very structurally unstable and a lack of skeletal congruency to the shoulder that may indicate surgery. Looking at some of the papers, I think the prevalence of a large and an engaging Hill-Sachs is probably a lot lower, maybe sitting more in the kind of 10 to 20% prevalence. But yes, so a Hill-Sachs would be a bone defect on the humerus. And then obviously don't forget about glenoid fractures. So you might end up with what's called a bony Bankart. So now not only have you disrupted the soft tissue, but you may have caused a glenoid fracture. Yeah. The other thing to stress here is that when we're talking, we generally focus on the young, athletic, sport-related traumatic injury, but you do also see a peak in elderly females. So when we think about instability in the population it affects, yes, definitely a young sportive population, but we also see a peak in the elderly females, and that's predominantly as a result of falls. So don't forget, in the older patient, falling could cause a fracture dislocation. So you will end up then possibly with a proximal humeral fracture plus it dislocated. And then we come on to talk about other associated injuries such as nerve injury and rotator cuff tears. Nerve injury itself is quite rare in the younger group. So in your sort of young population, the prevalence of nerve injuries generally in instability is about 10 to 15%, but is not common in that group. It is by far more common in the older group. So things to look out for is axillary nerve damage, any associated brachial plexus lesions, and then the other thing, obviously, in the older population is rotator cuff tears. But the prevalence of rotator cuff tears is around about 30%, but in the over 60 age group when it comes to a dislocation.
Okay, yeah, clear. So it's quite high numbers if I hear you talking about how much structural damage and how many different pathological pictures we can expect. And you already talked about
I think divide it into two distinct groups. Like I said, the younger group, you are mainly going to get instability lesions. Does that make sense? So it'll be labral pathology, capsular pathology, and some bony damage. In the older population, actually, it's going to be more rotator cuff, bone damage, and possible nerve injury that you may be dealing with. So recognizing the pathologies may be different. Yeah.
Okay. And you already mentioned for the TAPS or for the traumatic group, you'd see probably young, active, I don't know, more males than females. That's what I'm getting from the research.
Yeah, I mean, I think that is partly historical, but also, males generally engage in more contact sports. Now that could change. The great thing is we're now seeing women's soccer really picking up. The female rugby team. So it will be interesting to see that will we see this in both females and males as we both or could it be gender related? But yes, it's traditionally been a male group because of the sport related activities they do.
Yeah. Okay. So this is one group, and the other group you mentioned, elderly females.
Yeah, probably more. It tends to be more prevalent in women because one is that women are more prone to osteoporosis, so bone quality, and also females are tending to live a bit longer than males. So is it that we are seeing? But yes, we see a peak definitely in the elderly female group. I suspect due to bone quality, balance, and perhaps they're living longer, but then they're prone to these injuries. Yeah.
And is there also a typical patient for the other groups? Can we also say this is like a certain age range or
that's
gender?
Really good point. I'd say in the AMBRI group, the number of females to males is about equal. Does that make sense? So
Yeah.
if you're talking about AMBRIs, we're generally talking about an athletic population, throwers, swimmers. I don't think we generally see a big gender difference, therefore. What we might tend to see perhaps in the AMBRI group is you might see more females presenting with instability and pain, perhaps in the adolescent years, maybe because females tend to be more lax. So again, the other interesting thing about atraumatic instability is it could be related to skeletal maturity, hormones. So when you're getting that adolescent swimmer, some of those patients, they may be presenting symptoms also because of where they are in terms of their developmental stage. Yes, you're performing at a high level, you perhaps have hyperlaxity at the shoulder, but perhaps your muscular balance isn't kind of achieving what it requires you to do. But generally in the AMBRI group, I think the relative proportion of females to males is equal. In the type 3 and more of the kind of what we call the muscle patterning group, by far we see way more females than we do males. So at Stanmore, our experiences, we definitely see probably about 60% female versus 30-40% male. And our experience now is that a lot of these patients tend to come with other collagen disorders such as hypermobility spectrum disorder. So we are not just dealing with an unstable shoulder, but we are also dealing with instability in other joints. We're also seeing it with associated chronic pain syndrome, fibromyalgias. And what else is becoming complex about these patients is they come with a spectrum of symptoms, including anxiety, depression, abdominal pain, GI issues. So I think for me in our unit now, ASI is not really the diagnosis for this patient. These patients are probably more a chronic pain group, but atraumatic shoulder instability is one symptom as part of a bigger picture.
Yeah. Okay, thank you for your answer. If we move on and we look at your examination process, like how would that look in your clinic? And maybe starting from patient history and what kind of tests you use.
Yeah. So a patient history, I think, has got to be able to tell a really good story. Okay. So a good opening question for me is, I suppose a good place to start when I do clinic is kind of expectations. Why are you here? And I'm a shoulder plus, are you here with the expectation that we're going to manage your shoulder, and what does that possibly look like, is a good opening question. And once you've established that rapport, I think the important thing is I often ask with onset. So what was the initial onset of how these symptoms started? And then very quickly you can start to extrapolate whether there was an event or whether it was insidious. So onset of the problem. The other thing that's interesting is that if there has been an injury per se, it's really important to understand from the patient that was there at that time documented evidence of a dislocation. So for instance, I was playing football, I landed heavily, I felt my shoulder give way, I felt it come out, but then when I got up, it seemed to go back into joint. Yeah. So not only did it dislocate, but perhaps what was the mechanism of it being relocated? Was there formal reduction in an emergency department, or did it self-relocate or spontaneously reduce? No. That tends to then indicate that perhaps you may not, you could be dealing with a shoulder then that may be sitting more on the atraumatic side, despite the fact that it had an injury. So mechanism, how easily did it go back in? And then the subsequent symptoms that have happened as a result. So the recurrence, and what are your symptoms now? Can be useful, obviously, to ask about whether the patient can tell which direction the shoulder feels unstable. What movements do they feel limited in? So the classic would be that if they're anxious about arms away from body or above shoulder height, you're generally looking at an anterior direction. Oh. Or if it's a cross body, taking a top off, are we dealing with a bit more multidirectional or a posterior element of instability? So what movements are you finding difficult? What are you scared or worried about doing? What positions do you feel provoke the problem? Important to also ask about pain. So is pain associated with this? And then we talked a little bit about the site, whereabouts, and the nature of that. The other important thing I think that I would always include in my subjective history is asking additional questions about any other joint issues. So picking up, particularly in the AMBRI group, whether there is generalized laxity or hypermobility. Do other joints cause you trouble or feel unstable? It's an important question to ask, particularly in that group of patients. And for me, obviously, where I'm working, it's important to know what treatments have occurred already. So has the patient had any imaging, x-rays, MRA scan, but also any previous treatment or physiotherapy prior to coming to us is important. So understanding the story and the history, and also goals. What are your goals of treatment? And, that's going to be really important, because when we talk about shared decision making and management plan, are you dealing with a professional athlete? Are you dealing with a recreational, soccer player? Because this is really important, depending on what level they want to get back to, because the decision you make will be dependent on that rather than the pathology. Say, does that, if you have an individual who happened to get drunk, fall over, dislocate their shoulder, end up with a bony Bankart lesion, but is not going to be doing high-level sport or recreational sport, then the indication for doing a stabilisation is going to be quite low. Does that? Yeah. So the importance of understanding patients' expectations, what is it they're aiming to return to? Then coming into the objective, always useful to have. So I think just really keeping it simple, observe, possibly touch, and then move. Yeah. Observation, always just really good to just check for any obvious sulcus sign. So is the shoulder actually in joint, or is it looking out of place? No. Any obvious muscle wastage. Okay. I'm kind of, posture can be important, but in terms of I think what's probably more important is how does the position of the patient's posture change perhaps some of the symptoms. But posture per se is not a precursor to the feeling of instability. Yes. But perhaps in some of these more movement disorder patients, these atraumatic instability patients, it might be important to look at position of posture and chain and kinetic, and how does that influence the movement at the shoulder girdle. But otherwise, I think in a general setting, it's kind of look for muscle wastage, check that the shoulder is in joint, and if you're seeing it in acute setting, it probably makes sense to check for sensation and any particularly any axillary nerve damage or sensory loss in a traumatic or high level lesion. Once you've kind of looked and you've had a feel, obviously don't forget to check the AC joint, palpate the AC joint for any signs of pain, but also just check the AC joint for instability, and then move. So, a good standard shoulder assessment, looking at external rotation, hand behind back, elevation, inflection. And what you're really looking for is again, any feelings of instability, how they move there comfortably. Special tests, absolutely, to really be able to. That would have been my next question. Yeah. Problem, apprehension tests. Yeah, apprehension tests. So the anterior apprehension test, the relocation test, posterior apprehension. You can use draw tests, so that would be where you start to look at relative translation of the glenohumeral joint. Can be difficult to do if the patient is really anxious and they're guarding their shoulder. We would usually do this under examination under anaesthesia. So when a patient's asleep, you can look at relative laxity. Yeah. But again, it depends on how confident you are. But one sign that is helpful sometimes is I use the Gaggi's hyperabduction test, where I fix the scapula. I just abduct the humerus and look for particularly a degree of hyperabduction compared to the other side. What I'm looking there is that if there is a degree of inferior element of instability as well as anterior posterior. But apprehension tests are definitely your go-to special test for a diagnosis of instability.
Yeah. Okay, great. And say you figured out there is anterior instability, for example. And I mean, as physios, we want to check for impairments that we can modify. So is there a typical weakness that you would see, and how do you measure that?
Okay. Yeah, I mean, obviously, those are the very orthopedic mechanical tests, and you've prompted me very well to then obviously talk as part of that assessment. You know, my job and my role and expertise is definitely testing the muscular control. For me, I do now generally test the rotator cuff in supine and in prone. So I would usually lie the patient on their back, place the arm in a position of abduction or where the patient felt comfortable, and then test strength of both external and internal rotators throughout that range. So, for instance, taking the arm into external rotation where they're not particularly apprehensive, and then test isometric posterior cuff strength in a kind of what we call an inner range position, so where the muscle in its shortened position. Also then test resistance internally in that position to look at the anterior cuff. You can't exclude pecs completely, but the more in abduction, the more it'll bias to subscap. And then you're looking for internal rotation strength in the outer position, outer range of the muscle. And then I would also repeat it into internal rotation. So what I'm doing is I'm looking at rotator cuff strength throughout the arc of movement. Generally speaking, most patients with anterior instability of the shoulder tend to be weaker on external rotation strength. You can objectify that, so you can use a handheld dynamometer and measure that force and compare it to, let's say, the asymptomatic side, and or look at relative normal strength ratios for that age group. But I think in the clinical-based setting, the other way to really look to see if there is true, deficits is lag signs. So the other position is put them into prone lying, position the arm. Can they hold it there? Do you see a lag? I think for the vast majority of patients that in the traumatic group that people will see, it's kind of more, I suppose, a subjective feeling of, does this feel a little bit weaker? Usually your external rotation strength should be stronger than your internal rotation. So your internal rotation strength is stronger than your external. But yeah, I think some of it is a bit of subjectivity. Does it feel, and can these people take load? The other important thing is things like the anterior cuff and looking at things like the belly press test, the lift off sign. You know, can these patients perform and do good active control at the extremes of their movement and take resistance on it? And if they can't, is there an element of strengthening that up that could improve the control and balance of the shoulder? It becomes less, I think, now of just really looking at muscles in isolation as well. Also remember that as we test the cuff, we're also testing scapular stability as well. So the two are working in partnership. So for me, I do test cuff function in terms of strength in rotation, but I would also test scapular stability, particularly in prone. So can the patient take the load of the arm in scaption? Can the patient push with force to look at serratus? So I think it is important to look at the loading of the scapula in weight bearing positions. Can you single arm weight bear without the feeling of the shoulder giving way? Some of these exercises can almost be, some of these strength tests can also be part of your functional training and become part of your rehab program. I mean, keeping it simple, if they feel weak there, strengthen them there.
Okay, great. It's also a good segue to the following question, because you published a paper in 2012 about muscle activation patterns in patients with recurrent shoulder instability. What did you guys find out in this paper?
Oh my God, that's going back quite a long time.
You don't remember?
No, in 2012, I think. So I think we got to keep it focused to that this paper was pretty much addressing that atraumatic muscle patterning group. Okay, so these are not the traumatic patients. And historically at Stanmore, what we did when we saw these patients is we did fine wire EMGs, and we stuck needles into some key muscles: infraspinatus, lat dorsi, pec major, and anterior deltoid. We then asked them to perform standard movements such as flexion, abduction, external rotation. And what our neurophysiologist would then note was what muscle was activating. Now, we know what should activate in certain movement patterns. And what we were observing was that particularly lat dorsi and pec major were firing when we were not expecting them. So there was more activity in those muscles. For instance, when we were taking the patients into elevation, we were sometimes seeing lats firing, which is actually an extensor, not a flexor of the arm, or we were seeing increased activation of pec major. PEX does work on elevation, but we were seeing increased activation even when the patient didn't have load. Another example would be that when the patient was externally rotating, we would see lat dorsi activate, which actually is an internal rotator, not an external rotator. And at the same time, we were seeing reduced activation of the infraspinatus. So in those initial days, what we were starting to understand was that these patients were coming to us with instability. Some of them had had surgery on their shoulder and it had failed. Others had even had quite a lot of physiotherapy, but was still struggling. So that was where we proposed the concept that perhaps the muscles were the driver of the shoulders. So if your muscles work in an aberrant way, if there isn't a balance of your stabilizers holding your shoulder and your movers moving, if there isn't that balance and only one set of muscles is switching on, effectively movers but not stabilizers, that can result in translation of the humeral head. What that began to make us understand is that we need to look at not just strength, but also are people recruiting muscles at the right time in the right pattern to provide that stability.
Okay, so my follow-up question to this would be, if you find an aberrant recruitment of muscles, or that the global muscles are activating more, is there any way that we can normalize that in practice?
I mean, I suppose a simple way of looking at it is that if a muscle is working kind of almost too much, it means other muscles are not working enough. So you could even simplify it to the fact that then encourage what is weak to activate better, whether that be the rotator cuff, whether that be the scapular stabilizers. So you could argue, and it is interesting because probably my thoughts on this has changed, that maybe rather than trying to inhibit or decrease the overactive muscle, instead perhaps focus on strengthening what is weaker, or not antagonistically working. That will work in the majority of patients, but there are occasions that sometimes with some of our patients, we actually do have to get them to think about relaxing or actively switching those muscles off. That can either be through biofeedback, a feeling, can you try and, for instance, rotate the shoulder without this muscle activating? Yes. I think in this more complex group, the ones we are seeing, and I'm talking now about the type 3, I think the extremes, we are seeing more what we call a kind of dystonia, a movement disorder with high levels of pain that are kind of central sensitization. In the past, we looked at these patients in a very biomechanical way. So we tried Botox injections, we tried biofeedback, we tried relaxation strategies. We even in the past cut the pecs and the lats to tenotomize them and weaken them so they didn't pull on the shoulder and dislocate it. But I think now in our experience at Stanmore, we're recognizing that these really extreme hypertonic muscle activation patterns may be more related to the psychology of the patient. So it's more a neurological dystonia and or functional neurological disorder and or, I suppose, a chronic pain state. Does that make sense? So when you say Can we normalize this? Absolutely, in the vast majority, in a straightforward, but there is a subgroup of patients where the normalization is more complex because you're dealing with the brain and a neurological element, rather than it just being a muscle imbalance issue.
Okay, and I have a couple of questions, and I'm not sure which one I want to ask first. If we look at risk factors for recurrent dislocations, is there any evidence?
Yeah, I mean, I think the literature would generally talk about the fact that the biggest predictors for recurrence rates tend to be a bony Bankart lesion. So if you've had a first-time dislocation, and I suppose the degree of structural damage, a bony Bankart, higher levels of activity, so age. Okay, so the younger the patient, the active sport they're going to do. So people will talk about the fact that in the young male athlete with, say, a bony Bankart injury, the recurrence rate of that happening again may be anything up into the 90% region. If you are going to get a recurrent dislocation, it is highly likely to happen in that first year, or at least in the first 2 years. Probably a good person to, if you want to read a bit more around this, Margie Olds actually published a paper in the BMJ Open Sports and Exercise Medicine in 2019, and she looked at the New Zealand cohort of first-time anterior shoulder dislocations and looked at predictors. And her paper actually said that a bony Bankart, immobilization, so a period of immobilization, higher levels of shoulder activity, so the more the patient engages with their shoulder, higher levels of pain and disability, and interestingly, kinesiophobia, high levels of fear and re-injury were all risk factors. Interestingly, in her paper, she didn't see a big difference between whether it's your dominant shoulder or your non-dominant shoulder, and she didn't really find a difference. But in her paper with the age group, so the 16 to 24-year-olds didn't seem to have a higher prevalence compared to the 25 to 40. Okay, So, and also just to mention that Margie created a predict recurrent instability of the shoulder score. So it's called PRIS. If you Google it, or we can probably give a reference to the website, she's actually devised a tool which you can then use to help predict. But I would say is below 40, high levels of sport, bony Bankart are probably the highest risk factors for recurrence.
Yeah, and kinesiophobia is quite surprising, actually, as a risk
factor. That's
factor.
What's interesting, because I think that's something we haven't recognised and or addressed well enough. So I think this is really relevant. I think Margie's paper does start to discuss that we should not underestimate the fear of re-injury and levels of pain, and decreased quality of life seem to be predictors of it coming out again. I suppose, which comes down, and we're going to talk about management, about actually the quicker we get these people going, probably the better.
Yeah. And if we look at dislocation as a risk factor for osteoarthritis of the shoulder later on in life, do we know anything about that?
I have to say I'm probably not the expert with regards to giving you a really good academic answer to that, but I think in the sort of, when you think about orthopedic, in the orthopedic world, and when we talk generally with surgeons, there's probably a little bit of a split. That there is some feeling that those patients with a traumatic dislocation who have more than, it used to be 20% of bone loss, so a significant Hill-Sachs and a glenoid fracture, but probably now the threshold is even anything more than 10% bone loss. What you've effectively done is you've lost skeletal congruency. So if that patient is going to end up with recurrent dislocations, there'll be further bone damage, and therefore that could increase your risk of osteoarthritis. So to answer your question, I think the surgical, consensus would be is significant bone damage in a young patient with high recurrence rate, you may be better to operate. both to provide stability but to decrease the risk of osteoarthritis. However, what I would say to you is I don't think there are some proper good longitudinal studies for us to know that for sure. I mean, Hevelius back in Sweden now probably 40 odd years ago did a really good long-term follow-up of the instability patients.
Yeah,
and we do also know that over time these people stabilize. So, and a lot of those patients are not operated on. But I think bony damage is probably a factor. Now, interestingly, in the atraumatic group, so these are patients with no trauma, no obvious bony pathology, who can be recurrently unstable and literally popping in and out of socket perhaps several times, sometimes in a day. We have not seen any evidence of arthritis in that group, and that's important for the listeners to hear. So one of the first things I say into clinic is to reassure that, I know it's unstable, I know it displaces, but it's not causing any structural damage or increased risk of osteoarthritis to your shoulder.
Yeah, I will save the last question about your study results with like comparing surgery to physio in the atraumatic group for last. So that's I will talk to you about that later on. But a question that I always wanted to ask and I was wondering about is if someone has a dislocation, should we as physios relocate the shoulder, or should anyone else do it? Or should we say, like, don't touch it? That's what we were taught, I think, at uni. Don't touch it and let the ER doctor do it.
A quick, easy, the quickest answer when I talk about atraumatic, I think in an atraumatic instability, I see no reason why a physio can't help with relocation of that shoulder, which often actually involves just relaxing the patient and allowing muscle spasm to reduce. There's not been a big traumatic event. These shoulders are probably only partially out. But absolutely, we do that all the time at Stanmore. And in fact, we now teach patients how to self-relocate the atraumatic, unstable shoulder. And we have videos, which I'm sure I'm happy for listeners to access on a website to be able to guide patients. The trauma group, I think in the right skill set, you could argue yes, but I would be really cautious of the older patient. So I think an older patient with possibly a dislocation with an associated fracture that could be displaced, other pathology, it would obviously clearly not be wise to do that until you've got an X-ray. I think the general feeling at the moment is that in a high-level trauma, you are best to get an X-ray done, check what you're dealing with, and then you are then in a safe position to relocate the shoulder. Okay.
Yeah, good to know that. And before we move on to surgery, I wanted to ask you, we talked about examination and say, if we talk about a typical rehab program for a patient with shoulder instability, could you maybe take us through the process starting from, acute dislocation, or it can also be a patient without an acute trauma, from day one maybe till return to sport? How could it look like?
If we take the first time anterior shoulder dislocation, the recommendation is now to give a sling purely for comfort. So generally the guidelines are a sling for comfort. Let any hematoma settle, let any swelling and pain subside. But really we would only encourage these patients to wear a sling for no more than 2 weeks. So as comfort allows. And once a patient feels ready, they can pretty much start to get the arm going. I'd almost argue that there are no real limits. There is absolutely no limit with a first-time anterior shoulder dislocation once it's back into joint to start basically a strength loading program and do what they feel comfortable to do. I would have no issue of taking them even into an apprehension position and start loading it there. So for me, yes, there is healing. Yes, they are starting to get recovery. But if they are feeling confident and they're happy to go there, start loading it there. My personal feeling is the more we do expose them back into where they might be feeling anxious, the quicker we're going to reduce that kinetophobia. So that would be my approach. And that could be anything from isometrics to then isokinetic exercises to then functional training. But I would not say that you'd have to wait 6 weeks. Or do you see what I'm saying? I'm kind of, if the patient's ready, go for it. And that could include your closed chain weight bearing exercises as well. It's always, I think it's really important. Don't just think about strength and external rotation. So the other thing is I would focus on the anterior cuff as well. So things like belly press strengthening, internal rotation strength work, pushing off a wall. So don't forget that you need to strengthen the entire cuff. And then, if you're getting into a position where the muscles are taking load comfortably, it's not just about increasing load, then bring in speed. Can you do this faster? Can you drop and catch it faster? Can you react? Can you throw a ball? So I think the plyometrics and the more explosive things can come in earlier, exposing the patient to really what they've got to get back to. Following a first-time anterior dislocation, depending on the patient, if you've not repaired, there's no reason why you can't get these people back within that sort of 6 to 12 week time frame. Just as a way to point people to, there's the SINEX study that was done in Denmark by Birgit and her team, and they took your first-time anterior shoulder dislocation. They gave one group a home exercise program and one a more neuromuscular strength training program over a 12-week period. Now, both groups did well. There wasn't a high recurrence rate. The SINEX group did pretty well, but that's a lovely, really nice, simple program. They were getting them doing weight bearing, plyometrics, strength work, a lot, pretty much post dislocation.
Interesting.
Again, we're happy to provide references for all these papers. I think there was one. Was there one other? I think the thing for me is this interesting thing about reducing fear and kinesiophobia, and I think that's also about us as clinicians being confident that we can start doing this with the patients. So post surgery, it's interesting because we're just doing a Delphi consensus at the moment amongst the British shoulder physios and surgeons. And there doesn't appear to be an absolute consensus on what to do. So I would say what we're kind of sensing is that there is this feeling that after you've had a stabilization operation, you probably need to be in a sling around about 4 weeks. You can start active assisted exercises within what we call the safe zone. So what people are anxious about is not putting too much tension on the repair. So the movements they really don't want you to do early on is a combination of abduction and external rotation if it's an anterior stabilization. So as a group of experts at the moment, it's kind of, we do have some people wanting to do accelerated rehab and are saying, actually allow the patient to decide how long they wear the sling for, allow the patient to decide where the safe zones are. But there isn't an absolute consensus agreement that's coming out of our Delphi study, and we're in the process still of doing the rounds. So I think the guidelines at the moment will be post-op stabilization, put in a sling for probably about 4 weeks, allow the patient to do some active assisted and active exercise within safe zones. Generally, most experts don't want them to do any resisted loading until after about 4 weeks. And interestingly, it's a kind of combination of physical and psychometric factors that kind of dictate when the patient's ready to go back. But some clinicians still like to put a time point on it. So even though the patient might say, but I'm ready, I want to go and play football, and I'm happy doing a closed chain exercise, and I'm happy throwing and catching at speed, and you measure their strength and they're really strong. Interestingly, some clinicians have still got that feeling of, but you might not be ready to go to high level contact sport until you're at the sort of 6 month mark. And I think what will come out of our Delphi consensus is that we can provide some guidelines, but we actually need to do some good research and kind of really test accelerated rehab versus a more conservative management approach in a proper trial. So I think, sadly to say, I can't definitively say this is what you do, because even a group of experts can't seem to agree at the moment. But increasingly, I think we are getting more confident to get people back to sport, hopefully within a 4-month time frame.
Yeah. And that is a perfect segue to our last question about your research that you started in 2014. So correct me if I'm wrong, but you compared surgery versus physiotherapy in people with atraumatic shoulder instability.
Yeah.
Talk to us about that.
Yeah, actually, probably more accurate. This is a randomized clinical trial that compared an inferior capsular shift versus just a diagnostic arthroscopy. So we were literally comparing a sham placebo operation versus an actual tightening of the shoulder in patients with non-traumatic shoulder instability. We gained ethical approval in 2014. It did take us several years to recruit, but that's partly because this is not a common group. And we were asking patients to ethically approve to having a placebo operation. But we're really proud of the fact that we managed to achieve this. I just want to stress that it is really difficult to do a sham surgical trial generally, and I think the shoulder world has really kind of pushed that, what with the Seesaw trial and now with our trial. We recruited 68 patients. The patients were obviously blinded, so they didn't know which group they sat in. Only person who knew whether they'd actually had the operation was the surgeon. The physio was also blinded, and there was an independent assessor who took their baseline measures before they had the operation, 6 months afterwards, and then at 1 year and 2 years. So we did a 2-year follow-up study. Patients were also randomized, and the surgeon only allowed to open the envelope once they had done the arthroscopy. So they weren't biased before about whether they would operate on them or not. So the results have shown that all patients improved at 6 months. So there was pretty much a 40% improvement in both the diagnostic scope as well as the shift group. And that continued to improve at 1 year and 2 years. But I want to stress actually that the perceived global improvement was only moderate. So even when we've done this operation in the patients, on average, they make a moderate improvement. Not all of them get completely fixed, is one thing to say. When we then looked at the confidence intervals around their WOSI, which was the Western Ontario Shoulder Instability Score, that was our primary measure, there wasn't a real difference in terms of WOSI outcome for those who'd had the sham and the placebo. So there was no real difference between the two groups. In fact, if anything, at 6 months, the operated group, the shift group, actually scored 5 points more than the ones who just had the scope. So they were almost slightly worse at 6 months. By the time they got to 2 years, they were pretty much the same. So the conclusion of the study is that our recommendation is that a capsular shift does not appear to have any additional benefit compared to a placebo procedure. Therefore, we would be really cautious about recommending this in patients with atraumatic shoulder instability. What that could mean is the patients were getting better, not because of the operation, perhaps because it was a placebo. They believed they'd had an operation. Was it because they'd had the physio afterwards? Or was it that even they were in a sling for 4 or 6 weeks that could have contributed to an improvement in their symptoms? Our recommendation going forwards is that you might need to do other trials, and maybe there might be other surgical options that could help these patients. But what we probably could do is have more trials to look at physiotherapy efficacy. But our recommendation is physio should be the treatment for these patients at the moment.
Yeah, really great stuff. And do you know when it is published? Because I looked it up and it's not published yet.
Yeah. So we've just submitted the paper to the British Journal, to a journal. and we're just waiting now for peer review. So, hopefully we would be, it should be published this year. It has been presented and is being presented at several conferences, but absolutely this research needs to be disseminated, and we hope it's accessible for everyone this year. Yeah.
I think as an info for the listeners out there, we will put all the reference that you mentioned in the transcript, and also the study protocol of this trial. And I mean, as soon as we have the results, we will put them in as well. All right. I mean, we're coming towards the end of the podcast. Is there anything that we haven't touched on that you would still like to talk about?
No, but I think over my years and my journey, I think probably the key point, and it's really nice because the trial, I think, kind of says that, is that I feel now in my experience that actually it's all about what you believe that kind of gets you better. And I think as clinicians, my leaving point is, if you're confident, and you need to be confident, in your treatment, but also in what you can do with the patient, then the outcome's going to get better. And if the patient believes in you and the patient is confident, whatever the intervention might look like, they're going to get better. So I think for me, that's been the biggest learning curve, that as much as, yes, it's important about the biomechanics, and we've talked a lot about the pathology, and we can get perhaps quite focused on the exercise prescription. In my opinion, I think what really matters is what the patient believes and what you believe, and you have to work as a partnership. I think that's the key thing. Any intervention will work if you're going to believe in it.
All right. Thank you so much. And where can people find you, Anju, if they want to know more about you?
Well, I'm obviously on Twitter. So I'm at Anju Jaggi on Twitter. And that's kind of a way of sort of perhaps pinging me a message. But also I'm based at the Royal National Orthopedic Hospital, and I'm more than happy to share my email there. So that's anju.jaggi@nhs.net. We have a really good shoulder and elbow unit, and we are more than happy for people to come and perhaps pay a clinical visit to see complex cases, particularly difficult atraumatic shoulder instability, but also the kind of chronic rotator cuff pain issues and some of the shoulder arthroplasty work we do. But a good place to contact me is via my NHS email.
All right, great. Thank you so much, Anju, for your time and for your knowledge. And it was a pleasure to have you. And also thanks a lot for listening to this episode. To access the transcript and additional resources, make sure to sign up for a free Physiotutors membership on physiotutors.com, and also benefit from more useful physio content. If you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts. And also consider leaving a review if you really enjoyed it. And with that said, this was Kai for Physiotutors, and I'll talk to you in the next podcast episode. Bye.